been told that you have stage 2 mesothelioma based on your CT scan, and then after surgery, the pathology report says you're actually stage 3. Or your oncologist might refer to both your clinical stage and your pathologic stage as if they're different things. This can be confusing and scary. Did your cancer suddenly get worse? Today, I want to explain exactly what clinical versus pathologic staging means, why they're often different, which one is more accurate, and what these differences mean for your treatment and prognosis. I'm Terry Oppenheimer. I've been writing about mesothelioma and asbestos for the website mesothelioma.net for over a decade. I'm not a physician, and this is not medical advice. But understanding the difference between clinical and pathologic staging helps you interpret your medical information correctly. So let's start with what staging is and why we need two different types. Staging describes how much cancer is in your body and where it's located. The stages are 1 through 4, and they help doctors both predict your prognosis and identify the best treatment plan for you. Cancer is staged at different points in the diagnostic and treatment process using different information sources. That's why we distinguish between clinical and pathologic staging. Clinical staging happens before surgery, using information from physical examination, imaging studies like CT scans, PET scans, and MRI, and biopsy results showing what type of cancer you have. Your oncologist looks at these results and assigns a clinical stage based on what the images show and what can be detected without surgery. Clinical staging answers the question, based on what we can see and detect non-invasively, how extensive does the cancer appear to be? The clinical stage is designated with a small c in front. For example, it might read CT2NO blah, 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 meaning the designation is derived from imaging studies. And in this example, the rest means that the tumor appears to be T2 size. Pathologic staging, that happens after surgery, using information from direct surgical visualization. That means what the surgeon actually saw when they opened your chest or abdomen, combined with a pathology examination of all the removed tissues, including the tumor, lymph nodes, and organs, and microscopic examination showing exactly where cancer cells were found. Now, before I go on, I'm going to take a break here to ask you a quick favor. If you find these videos helpful, please hit the like and subscribe buttons below. It makes it easier for other people who need this information to find us. Also, if you have questions or if there's a topic you'd like to see addressed in a future video, send me a note in the comments section. And make sure you watch until the end because I'm going to give you valuable information on where to find resources that will make a real difference for you. Pathologic staging answers the question, based on what the surgeon found and what the pathologist saw under the microscope, how extensive is the cancer actually? The pathologic stage is designated with a small p. So a reading described as PT3N1MO starts with a P for pathologic stage, meaning it's based on surgical findings. And in this example, the rest means that the tumor was actually T3 size and extent, one or more lymph nodes were positive, and no distant metastases were found during surgery. Why are clinical and pathologic stages often different? Because imaging has limitations. CT scans and PET scans are excellent tools, but they can't see everything. Small areas that a tumor has spread to might be invisible on imaging. Lymph nodes that look normal on CT might actually contain microscopic cancer cells, and a tumor might have invaded structures in ways that aren't apparent on imaging. So, clinical staging based on imaging often understages disease. That means the actual extent of cancer is greater than what the imaging showed. It's less common, but clinical staging sometimes overstages disease. A lymph node that looks enlarged and suspicious on imaging might be inflamed rather than cancerous. What appears to be tumor invasion on CT might actually be inflammation or scar tissue. Surgical exploration has the advantage of providing direct visualization. The surgeon can see and feel tumors, check whether cancer has invaded into structures, and remove suspicious lymph nodes for examination. This provides much more accurate information than imaging does. When all is said and done, pathologic examination is the gold standard. The pathologist examines tissue under a microscope and can definitively identify cancer cells. A lymph node that looked normal to the naked eye might show microscopic cancer cells under the microscope, or a suspicious area might prove to be inflammation without cancer. Here's a concrete example of how staging might change. Your CT scan shows a tumor on the pleura of your right chest, no lymph node enlargement, and no distant spread. Based on this, you're clinically staged as T2N0M0. That's stage 2. You undergo pleurectomy decortication surgery, and during surgery, the surgeon finds the tumor has invaded through the diaphragm into your abdomen. That's something that wasn't apparent on imaging. After the operation, a pathology examination of 8 removed lymph nodes shows that 2 contain cancer cells. The nodes weren't enlarged, so imaging didn't detect involvement. Based on surgical and pathology findings, your pathologic stage is T4N1M0. That's stage 3. Your stage went from 2 to stage 3 not because the cancer suddenly progressed, but because your surgery revealed the true extent of your disease that imaging couldn't detect. Does this mean the clinical staging was wrong? Not necessarily. The radiologist interpreted the imaging correctly based on what was visible, but imaging's inherent limitations mean it can't detect microscopic disease and subtle invasion. Which staging is more accurate for prognosis and planning? Pathologic staging is more accurate because it's based on a direct examination of tissue. Studies indicating a cancer prognosis uses pathologic staging when available because it more accurately reflects the true extent of the disease. If you haven't had surgery, clinical staging is all you have, and it's what's used for treatment decisions. But if you have surgery, pathologic staging supersedes clinical staging for prognostic purposes. Treatment decisions might be based on either clinical or pathologic staging, depending on the timing. Before surgery, the clinical stage helps determine whether you're a surgical candidate, while after surgery, the pathologic stage helps determine whether you need additional treatment like chemotherapy or radiation. What if your stage goes down after surgery instead of up? Unfortunately, this is less common, but it is still possible. Imaging might suggest extensive disease, making you appear to be stage 3 or 4, and then surgery finds less disease than expected. What looked like a widespread tumor on imaging was partly inflammation or fluid. Lymph nodes that appeared to be involved are negative for cancer. Your pathologic stage might be lower than your clinical stage. And this is good news. You had less disease than feared. How should you think about staging changes? If your pathologic stage is higher than your clinical stage, understand that this reflects better information, not disease progression. The cancer was always as extensive as your surgery revealed. It's just that now you have more accurate information. And this might change the recommendations for additional treatment you're given. If your pathologic stage is lower than your clinical stage, this is encouraging. You had less disease than imaging suggested, and your prognosis might be better than initially thought. What questions should you ask about staging? Start with, what is my clinical stage based on imaging? If I have surgery, could the pathologic stage be different? If my stage changed after surgery, does this mean the cancer progressed? What does my pathologic stage mean for additional treatment recommendations? Which stage should I use when looking at survival statistics? Understanding this staging can evolve as more information becomes available, helps you interpret changes without assuming the worst. Often, a staging change simply means better, more accurate information rather than disease progression. For patients who don't have surgery, clinical staging remains the basis for treatment decisions and prognosis. Clinical staging is less precise than pathologic staging, but it's the best information available without surgery. To review, clinical staging uses imaging and physical examination before surgery to estimate the extent of disease. It's designated with a small c. Pathologic staging uses surgical findings and microscopic tissue examination after surgery, and it's designated with a small p. Pathologic staging is more accurate than clinical because the imaging on which clinical diagnosis is based can't detect microscopic spread or subtle invasion. Stages often change from clinical to pathologic, usually going up because surgery reveals more disease than imaging showed. This reflects better information, not progression. Pathologic staging is the gold standard for prognosis. Visit mesothelioma.net for more information about mesothelioma staging and treatment planning, or call 1-800-692-8608 or use the live chat feature on the website to speak directly to one of our helpful patient advocates. As for me, remember to post questions below, and I'll see you next time.